So hi, everyone. Thank you so much for joining us today. Welcome to the March Research Seminar Series. My name is Maria, and I am a program assistant with the BC Brain Wellness Program, and I will be hosting today's session. We are very excited to have Dr. Vila-Rodriguez presenting today on non-invasive neurostimulation therapies and how this research can help our understanding of brain conditions and how it can have a positive impact on healthcare. Before we dive into the session, I would first like to acknowledge that the BC Brain Wellness Program at the Javid Moafagian Center for Brain Health is situated on the traditional, ancestral, and unceded territory of the Hunkaminam-speaking Musqueam peoples. I would like to invite you all to take a moment to acknowledge and give thanks to the land that you are joining us from today. Additionally, I did also just want to point out a few housekeeping items to keep in mind. If you have any questions or comments throughout the session, please feel free to send them in the chat box and we will get around to them during our question and answer session at the end. As well, we will be recording today's session and uploading it to the BC Brain Wellness Program YouTube channel in case you would like to view the session later on. Without further ado, I would like to introduce our wonderful speaker, Dr. Vila-Rodriguez. As a clinician scientist, Dr. Vila-Rodriguez has a strong interest in conducting translational research that bridges our understanding on the neurobiology of psychiatric disorders with clinical applications of this knowledge. Dr. Vila-Rodriguez's clinical practice is actively focused in those most afflicted by such conditions, and his research interests are directed at finding novel therapeutic interventions within non-invasive neurostimulation therapies that can help mitigate the suffering of those with forms of psychosis and depression. In Dr. Vila-Rodriguez's lab, all forms of non-invasive neurostimulation therapies are investigated. And without further ado, I would like to pass it on to Dr. Rodriguez.
Thank you so much, Maria, for your kind introduction and for the opportunity to come back to the wellness program sessions. It's always a very good opportunity to connect with people and that matter the most. And I always take a lot of really good ideas from interacting directly with the people that we look after and that we care the most. And I'm very excited. I'm gonna share my screen now so that everyone can see the first slide. And I'm hoping that now everyone can see the first slide.
Yes, looks good.
Perfect. This is the topic today is something that is really close to my heart because the way I got to work with this technique, convulsive treatment, and the way I got into contact with people suffering with Parkinson's goes back to the time that I was just a recent graduate from the psychiatry program here at UBC. That was now a few years ago, back in 2011. And at the time when I started my clinical practice, I had an opportunity to do a locum for a psychiatrist who was looking after people who were receiving ECT as outpatients. And I vividly recall that one of the people that I kind of took over for during that substitution was someone who had a diagnosis of Parkinson's and was receiving ECT as an outpatient. And my first impression, the first time that I saw that person in an outpatient visit was like, wow, this person is doing great. They are older adult, but they are very active. They have a kind of independent living. What are they doing in the clinic, kind of receiving ECT? And so I went back to the chart, to the notes, and I looked, and to my surprise, This person had had a couple of admissions to hospital due to depression. Parkinson's was not doing well, and it was starting ECT, and then that was kind of like a different person that I was seeing before my eyes. And so that really sparked my interest because, you know, I had known already by that time that electroconvulsive therapy works really well for depression, for psychosis. But this new aspect of Parkinson's, like, wow, I've not heard that much. So I started to learn more about it. And that kind of led to me kind of reaching out to colleagues in the Department of Neurology, Dr. Stossel, Dr. Creswell, Dr. McEwen. And over time, eventually I started working at the clinic here at the Pacific Parkinson's Clinic. And since 2015, doing clinic and seeing people who struggle with Parkinson's and psychiatric symptoms. And eventually with Dr. Creswell, we said, hey, why don't we do some research on this new treatment called magnetic seizure therapy. And so that's how I got here. And that's what I would like to share with all of you. And I made an effort to have a lot of time for questions. And so I'll try to, I tend to talk a lot. And then once I get really into it and very enthused, I can just keep talking. So I'll restrain myself, and I'm really looking forward to discussions with all of you. These are my disclosures. I understand this session is being recorded, and if there are any concerns or anyone wants to reach out about any of these, please let me know. But yeah, mostly the lab is supported by a number of public funding agencies, including recently the Western Brain Institute to fund this clinical trial using magnetic seizure therapy for Parkinson's. I'm hoping to introduce to everyone magnetic seizure therapy as a novel treatment for Parkinson's and depression. Also talking about magnetic seizure therapy, or MST, necessarily makes us to talk first about the well-established treatment, electroconvulsive therapy, and discuss in what way they are different and why we really want to pursue and want to understand whether magnetic seizure therapy might be a substitute for ECT. And last but not least, introduce an ongoing clinical trial that we have going, where we treat people with Parkinson's and depression with this novel treatment. So the first stop here is to acknowledge something that I'm very pleased to see that is evolving in this direction, which is it's related to the fact that in medicine in general, we are becoming to appreciate that illnesses are complex. They present affecting many different areas of a person's life. It's not just a core number of symptoms. And the Parkinson's Center here at UBC, I think it's really pioneered in, because it's been for a long time, that all neurologists, everyone in the team, appreciate that Parkinson's, in addition to the well-known and for a long time well understood motor symptoms like the tremors, like the rigidity, the stiffness, it also presents with what it's called the non-motor syndrome. So symptoms that present in the context of Parkinson's that are not related with motor system. And one of the most frequent ones is depression. Around 50% of people with Parkinson's will have depressive symptoms over the course of their condition. And an estimate of 20 to 30% will at some point meet diagnostic criteria for depressive disorder. The second on the list, really close, is anxiety symptoms. The estimate is around 30% of people reporting anxiety symptoms and anxiety disorders in the context of Parkinson's. So these are not only very frequent, but they also get in the way. And in clinic, when I see people in consultation, again, and there's a bias there, right? Because if they get to see me, it's because there's something that it's not working well, or that something that we need to look at. But many times, the majority of times, the motor symptoms are more or less well controlled. The treatments, thankfully, work for tremors, for rigidity, and so that tends to be well controlled. But the anxiety, the depressive symptoms, they get in the way. So it's an area that it's very important to address. And very often I get this question. Parkinson's is a condition that tends to present late in life, and as opposed to many of the illnesses that I look after, people who develop Parkinson's kind of develop their full potential before the diagnosis of Parkinson. That's not the case in conditions like schizophrenia or severe depression, where it impacts people early on in their lives, in their late teens, early 20s, and that has a carryover effect. In Parkinson's, I found that's a striking difference. Most people, the Parkinson's diagnosis comes as a existential slap on the face. No one thinks of their retirement years as having to deal with Parkinson's, considering that the trajectory up to that point has been developing the full potential. So it's a major shift. And people often ask, well, such a transcendental diagnosis that has such an impact, isn't understandable that people might feel sad about it, that might react to the diagnosis. So in psychiatry, that's what we call an adjustment disorder. When there's a life stressor, a situation that impacts the individual's life to such an extent that there's not only a reaction to it, but there's some mild symptoms that are associated with it. Depression is different from an adjustment disorder. And this relates back to the idea of illnesses being complex. Depression is a complex medical condition where at the core, the symptom is profound, persistent, and detached from circumstances, sadness, low mood. But it also presents affecting other areas: sleep, level of energy. One core symptom is lack of enjoyment. And so that's what makes an adjustment disorder different from depression. Depression is this illness. It presents with beyond, in terms of severity and in terms of the constellation of areas that it affects, beyond what would be understandable or expected to a life stressor. So I think that's a first and important aspect to touch on, and to help people reflect on their own experiences and kind of where they see whether there's someone is struggling with an adjustment situation or more with depression. There's effective treatments for depression. And in the context of Parkinson's, that's also the case. Talk therapy, counseling can help a great deal with that aspect of adjustment, that aspect of, looking at the diagnosis of the condition and the impact that is having on the person's lives and their and their family, their relatives. That helps a great deal. Antidepressant medications can also be used and are effective, work a lot of the times. But unfortunately, there are a significant proportion of people that medications either don't work or are not enough or are associated with unpleasant or not just unpleasant, but significant side effects, increased weight, sexual side effects, other side effects. So there's a need to investigate, to come up with alternatives, with new treatments that can help in this situation when standard treatments like talk therapy and antidepressants are not helping. So that's where these treatments known as convulsive and non-invasive neurostimulation therapies come to place. They are non-invasive in the sense that they do not require surgery. So in the context of neurostimulation, we kind of distinguish between treatments like deep brain stimulation, that it's also used in Parkinson's, that requires brain surgery, to treatments like transcranial magnetic stimulation or magnetic seizure therapy or ECT that do not require surgery. It's convulsive because the treatment relies on triggering a convulsion, on triggering a seizure. And I fully appreciate that this is very counterintuitive, always. Whenever I talk about ECT, electroconvulsive therapy, or magnetic seizure therapy, the idea of triggering a seizure as a way to help is counterintuitive, because outside of ECT or magnetic seizure therapy, a seizure is an expression of an underlying illness. So there's a group of conditions called epilepsy where there's an underlying issue in the brain that manifests with the seizures. So thinking of triggering seizures to help is like, this doesn't, well, how can I explain that? And so I'm going to show you in a minute what happens when you trigger a controlled seizure from external energy and how different is that from epilepsy. The seizure is triggered by means of a brief, very brief current, just a few seconds. And it's done under general anesthesia because we don't want the person to be aware of a seizure being triggered. So it's in terms of comfort, but it also makes the treatment very safe. It's done with a team of nurses, anesthetists, and psychiatrists, and there's a very tight control of vital signs and monitoring, and it makes this treatment extremely safe. So why is triggering a controlled seizure so different from epilepsy? To begin with, there's not that illness. That illness is not present. So it's not that there's an illness, there's something in the brain that is triggering the seizures. And second of all, triggering a controlled seizure is associated with a lot of change in the physiology of the brain that can be leveraged to treat different conditions. So there's been reports showing that there's increase in glial cells. It's a type of cells in the brain, along with also in animal models, there's an increase in neurons, in new cells. And that's in an area of the brain called the hippocampus that it's involved in memory and other brain functions. Triggering a seizure triggers a massive release of these chemicals, these neurotransmitters called catecholamines. One of them is dopamine. We know that dopamine is very important in Parkinson's. It's one of the key features in Parkinson's is that the cells in the brain that produce dopamine get affected and there's less dopamine. So with ECT, with magnetic seizure therapy, there's a massive release of that neurotransmitter. There's regulation of dopamine circuits. That's going to be very important. There's also release of this other inhibitor neurotransmitter called GABA. There's regulation of the endocrine system. And there's even release of good chemicals that help the brain stay healthy, like this called neuronal growth factors. So all things together present a treatment, ECT and magnetic seizure therapy, that it's almost like a reset of the brain, like booting up a computer, refreshing it. And there's a lot of things that happen. And what it boils down to is, because so many things happen with this treatment, it can actually help in many different conditions. That's why when I explain the many different things that happen with control seizures, that's where people start to then understand why ECT can be used to treat depression or schizophrenia or refractory epilepsy or Parkinson's. Like, if you tell first people that you use this treatment for all these many different conditions, they go, how is it possible that that same treatment can help in such a diverse number of brain conditions? That's because it does a lot of different things. So a little bit more emphasis on dopamine. And again, if I go back to 2011, when I started learning about the use of ECT in Parkinson's, these were papers back then that I started to look into. And to my surprise, they're kind of quite old now. It's from the 1990s. So that was a surprise that I had back then. I thought, well, nobody knows about this. No, people have known for quite a number of years that ECT specifically is associated with an increased release in dopamine in an area of the brain that it's very important for motor control, which are the basal ganglia. And it's been shown as well that it has a preferential effect on two types of dopamine receptors without affecting a third type, the dopamine 2. This is really important in terms of understanding how ECT improves symptoms of Parkinson's, not only for depression, but also for motor symptoms. That was also a surprise. I thought of ECT back then as helping with depression, with psychosis, but to my surprise, I found that there's a lot of scientific evidence that shows and that explains how ECT can help with motor symptoms in Parkinson's. This is taken from this paper in 2011, where they show this increase in dopamine with this technique called SPECT. And the image on your left is the image before getting ECT, and the image on your right is after getting ECT, and comes from a single person. And they showed that there's an increase in that dopamine function in this area of the brain, the basal ganglia. And of course, in this case, it was associated with improvement, you can see, in depressive symptoms. So again, digging even more, I started to find more and more papers and information about the use of ECT, and they go even back further. Like the first case reports are dating from 1970s actually. And so there's a list, a recent list, 2015. What you can see is that until now, the ECT is being used a lot to treat depression or psychosis in the context of Parkinson's. And with Dr. Creswell, a psychiatry resident, now a graduate from the program, Dr. Ainsworth, and a medical student, Isaac Roden, we thought, let's look at our own experience. And so what we did was a chart review of people that we had been treating with ECT in the last, at the time, 4 years, between 2014, 2018. And we, at the time in 2018, we had treated eight people. And not surprised, because at this point, we already knew that this was the case. The majority of people improved not only of their depressive symptoms, but what we describe in this paper that I have shared and that will be circulated for anyone who's interested in kind of reading more details. A lot of the patients that we treated also improved on motor symptoms and the autonomic effects. And one of the particularities here is that we use a way of delivering ECT that focuses on delivering the treatment to the frontal lobes, which reaches better to the basal ganglia. So this was our contribution, and what led us to think, okay, maybe we should look further into this. There is a summary of the things that we saw in our own study and what we've seen in the literature. So definitely helps with depression, definitely helps with psychosis in the context of Parkinson's, but it also helps with dyskinesias, which are oftentimes in the context of Parkinson's are motor symptoms that tend to present over time as the effect of Parkinson treatments kind of accrue over time. Freezing on and off phenomena that many times are associated with anxiety, with tension, they also got better. Balance, small print, and to my surprise, the last one, anosmia, which is a feature, a symptom that is frequent, but maybe not the most frequent, is many people struggle with sense of taste, smell in the context of Parkinson. There were a couple of people that I treated with ECT that, to my surprise, told me, oh, by the way, it seems like I've noticed that my sense of smell is kind of a little bit better. And the first time that I heard that from one of the people that we were training, I go like, oh, really? It was surprising, because that tells me that there's something happening there that is related to smell that is very intriguing and interesting to pursue. So again, how can a treatment affect so many and diverse areas of improvement? That's because the way it works, it affects a lot of many different neurotransmitters, different chemicals, and different aspects of brain health. This is from one of the people who received ECT, shared with permission, and it's a close-up of just a part of their writing of how they wrote before getting any ECT and after ECT. Even though the size of the letters did not significantly increase, the print, and there's more to this, significantly improved. So for me, it was like, oh gosh, so I can really see the effect of the treatment. We also did maintenance for 6 of the people who got the initial acute course of treatment, and they maintained a really good improvement with just 1 treatment every 4 weeks. And this point was really striking to me. I did not expect ECT, and particularly one way of delivering ECT, one of the side effects that is associated with is with transient memory difficulties. And to my surprise, we always ask and make a lot of emphasis on monitoring whether there are side effects. And we ask, well, are you experiencing any difficulties with memory? And people said, no, not much. It was striking. Again, this was in clinical practice. We did not have an opportunity to do detailed testing and have cognitive tests, but it was striking. And this is something that we want to look in more detail in our clinical trial. We have a battery of cognitive tests because we want to see whether there are any side effects, but we suspect, and we have some data, that maybe there are some improvements. But again, that's a research question at this point. So to summarize, ECT, electroconvulsive therapy, is safe and effective neurostimulation treatment. It's indicated both for depression and psychosis in the context of Parkinson's. It can help with motor symptoms. And maybe it might be associated with fewer memory side effects. So that's all these data prompt us to send this request to the Western Brain Institute to do this clinical trial with magnetic seizure therapy. And before I go to the last few slides talking about MST, at this point, maybe some of you are wondering, well, why don't we do it more often? Why don't we do ECT more often if it works so well and is such an effective treatment? And I think it's complex, it's complicated. There might be more factors, but in my experience, one key aspect is related to stigma. And it's interesting because nowadays, when I ask and when I use and I bring up this movie, the people under 30 look at me with a puzzled look. It's like, what are you talking about? But anyone my age or older knows perfectly well One Flew Over Cuckoo's Nest. And it is an excellent movie. It portrays a time in psychiatry in the 1960s, 70s, and reflects what was happening back then. But it's made a lot of harm in terms of portraying and causing a lot of stigma for this treatment, for ECT, which is a life-saving treatment for a lot of people and a treatment that works really well. So one way to overcome stigma is engaging in conversations, listening, addressing people's concerns, but also looking for alternatives. And that's where we thought, all right, let's look at magnetic seizure therapy. This is not ECT, and I'll explain why it's not ECT. But magnetic seizure therapy, or MST, is a treatment that works with this physics principle called electromagnetic induction. And for those of you who share my lack of physics background, I found it helpful, a little gadget that a former student in the lab did when they were here. I'm going to try to do a little show and tell, and hopefully that this works. But what you see here is a miniature, a small magnetic seizure therapy device. We have a source of energy, batteries, we have electronics here, and we have a loop of wires, which we call the coil. When current flows, a light goes on to show us that current is flowing, right? What we don't see is current is flowing through this loop of wire, and we are not seeing anything here. But you have to imagine a a donut, literally a donut on top of this wire. So this is the MST device, and this represents, go figure, a brain. It's another loop of wires, is a conductor, and it has a light attached to it. So if current is induced here, the light should go on. So I press on, and look at that. Let me show this here. If I go further away, the light stops. I get it closer and it gets on. There's no cables in between. You can see it. There's no contact. I'm inducing current wirelessly. It's three-dimensional. It's underneath as well. This is what electromagnetic induction is a physics principle. And what I'm showing on the slide is a commercial application of this. We can recharge gadgets without cables. That's electromagnetic induction. What is the advantage of this? And by the way, this is the actual magnetic seizure therapy device. It's the same principle. There's a source of energy, so it's connected to the current. Inside the big box, there's electronics. And this part here is the cone, the coil with the loops of wires that is put in proximity to the head to elicit that and induce that current. What is the main difference between ECT and magnetic seizure therapy? This is the main difference. And now let me kind of walk you over what we are seeing here. What we are seeing here is what it's called electric field modeling. You know, we come up with fancy words for everything, but what we are seeing is how much dose, how much current we deliver, it gets to the brain with each of these treatments. So the more red, the more current that is delivered. And what you see in blue are three different ways of delivering ECT, electroconvulsive therapy. And depending on where you put the electrodes, the dose reaches different parts of the brain. A few minutes ago, I mentioned that in the people that we treated with Parkinson's and that we reported in that paper received these particular placement bifrontal, the current reaches predominantly the frontal lobes and the basal ganglia. Now, in red, we have a magnetic seizure therapy coil. Look at that. The magnitude of the current that we induce is several-fold less than with ECT. What is more, what we do with magnetic seizure therapy is triggering the seizure in the outer part of the brain. It's called the cortex. The current does not reach deep inside, which spares areas that are involved in memory. So we have a lot of data, and that's the main. A seizure makes a difference in terms of side effects. And that's what we've seen. And the reason why we felt there was a very strong rationale, reasons to pursue a study to look at the use of magnetic seizure therapy in Parkinson's was magnetic seizure therapy has been used in depression and in major depressive disorder. And it's shown, I'll show you in a second, that it works. And we also know that ECT works for Parkinson's. So it made a lot of sense to request funding to investigate this directly in people who have both Parkinson's and depression. And there are ongoing trials, clinical trials happening for major depressive disorder, but this comes actually from Toronto at the Center of Addictions and Mental Health, where they've conducted the largest to this date trial using magnetic seizure therapy, MST, for depressive disorder. And what they found is that around 60% of the people who receive the number of treatments that they need, that's what per protocol means, achieve around a 60% response rate. What is more important, 50% achieve what is called remission, so barely any symptoms left. And the conclusions of the trials that have been done to this date in major depressive disorder is also that the side effects related to MST are less than ECT. There's fewer cognitive memory side effects that is safe and well tolerated. So that's what prompted us to say we should do a study in Parkinson's, in people who have Parkinson's and depression. And that's what's happening now. It's in collaboration with Dr. Creswell at the Parkinson's Center, and is funded by Western Brain Institute. And we'll share some additional information with an infographic about the details of the trial. And this is the email of the research coordinator for the study, Michelle, who I believe is on the call attending. Questions? Thank you so much for your attention.
Wonderful. Thank you so much for this wonderful presentation on non-invasive neurostimulation therapies. We truly do appreciate your insight, and I'm sure that we all learned a lot. I particularly myself like the demonstration of the MST and the electromagnetic induction gadget. I found that very interesting. So if you have any other questions, feel free to send them in the chat. We have gotten a few questions throughout the session, which I will just read out, and then Dr. Vila-Rodriguez, you can just address them. One question that we have here is there a way that researchers are differentiating between clinical depression and pain distress?
That's a very good question. And that goes back to differentiating, for example, an adjustment disorder from a major depressive disorder. The key idea is that the illness, depression, presents, number one, with a core aspect of sadness and low mood that goes beyond what one would expect for a person. And again, I appreciate that there's the aspect of vagueness of how do we measure that, but it's both at the same time difficult but really easy. Relatives tell you, people tell you themselves, like, you know, I've had XYZ stressors in my life. I've got situations that made me sad. What I'm going through now is different. So that aspect, it's at the same time, it's difficult to measure. We don't have a test, but at the same time, people do experience that difference. Number two, it's not only the low mood, it's the constellation of other symptoms. Changes in appetite, weight, sleep, enjoyment. When all those things present together, is not just a reaction to something, it's something more. It's an illness of the brain where different brain circuits are not working as they should and present with these symptoms. So the same applies for chronic. I think the question was for pain, right?
Yes, pain distress. Yes.
Yeah, it's a very common situation where sometimes we develop chronic pain, and then eventually sometimes there's depression, sometimes there's an adjustment disorder. We go about the diagnosis the same way.
Yeah, perfect. Thank you so much for clarifying that differentiation between the clinical depression and the pain distress. We do have another question here. Is this considered a form of brain rewiring or neuroplasticity? That's
right on the money, right there. we do have, and I didn't want to overwhelm with that, but we have data. We've done imaging of the brain before and after magnetic seizure therapy, and we show that there are brain changes associated with the improvement of symptoms. So definitely, we believe that one of the ways that both ECT, magnetic seizure therapy, or even transcranial magnetic stimulation work is through this general principle of brain plasticity, just kind of rewiring. That's right where, yeah, we think that's one of the things that is happening, and we have some evidence, and we continue to work on showing whether that's the mechanism. Yeah.
Right, wonderful. Another question here is, has MST been tested on people with advanced Parkinson's?
The answer is no, because we are the first ones ever to do magnetic seizure therapy in Parkinson's. Magnetic seizure therapy has been used now quite a lot for major depressive disorder. We also have a study that does magnetic seizure therapy for bipolar depression, and we're starting another one in schizophrenia. But for Parkinson's, we are collectively here in British Columbia pioneering this here. So yeah, we've used. By the way, sorry, Maria, sorry to interrupt.
Yeah, no worries.
I realized that I kind of not address maybe one aspect of the question. We have used ECT in advanced Parkinson's. So I realized that there were maybe different layers to the question. And the answer is that in advanced stages of Parkinson's, it's where I've seen the most dramatic effect, positive effect on motor symptoms, actually. So.
Okay, perfect. A similar question is that this treatment is very exciting, but a question here is if we are on the cusp of a revolution in treatment for psychiatric disorders with this treatment?
Well, you're asking someone who is completely biased about this, and I would say absolutely yes. But just to share a little bit of the factual information, not just my enthusiasm, I think it's grounded on the reality of, number one, the efficacy of ECT. Now we have a new treatment, a new way of doing this that has potentially fewer side effects, but we also have transcranial magnetic stimulation. And in a few weeks, we are getting a new device that is going to do focused ultrasound. And so we are, and there are a lot of very, very exciting research happening that seems to be changing the paradigm from a time when for brain health we've used as treatments predominantly only medications, and we are shifting to add to the toolkit an array of new treatments that are more targeted, that just target particular brain circuits that are more specific. So again, I am biased, but I do believe I'm grounded on reality, and what I see is happening around neuromodulation treatments.
Right. So in terms of the outcomes between the MST and ECT, a question that just popped up is, could MST work for someone who didn't benefit a lot from ECT?
I would say that probably not. But I want to be cautious because in clinic, I've seen in consultation, often people referred that the information that I received was ECT did not work. And upon learning more, in a lot of situations, what happens is people might have not received enough number of treatments. It was stopped early because of side effects, or they were not triggering seizures, or the right placement was not tried. So that's the cautionary tale that I would have in the situation that I have seen people that came with that label, treatment, ACT did not work. The first thing that I would do is just double check, what do we mean by it did not work? Now, to address directly the question, if I were to see someone and we checked and the treatment did not work for them, then MST would not have a very good chance to help. I think that's fair.
Okay. And similarly, how long is the treatment? I believe this refers to MST.
Yeah, and I usually have a slide where we show that the treatments are delivered twice a week. And here at UBC, it happens on Tuesdays and Thursdays around noon. And we deliver anywhere from 10 to 15 treatments. So if you do the math, it's around 6 to 8 weeks of treatment twice per week. And the treatment itself is actually very fast. Again, the stimulation lasts very few seconds, and the person is under anesthesia literally for less than 5 minutes. And so it's more the preparation that takes more time than the treatment itself, and people go back home after the treatment. So it's an ambulatory procedure.
Right, that's wonderful. Thank you for answering that question. We have lots of questions popping up here, but another one is, what would be the range of radiation of EMR in comparison to MST, and if there are any thermal effects?
Excellent questions. We are getting to the physics aspect of it. Number one, definitely no thermal effects. The level of energy that is delivered is several fold below any thermal effect, which would be a concern, of course. And I've not seen any direct comparisons with cell phones or towers for MST, but for transcranial magnetic stimulation, and I don't want to scare anyone, but having a cell phone to your ear gives you a lot more radiation, electromagnetic radiation than TMS, or, and I don't know for MSC, but I suspect it's the same case. You have to think again that the treatment is really fast. So even though we trigger current, the number of individual pulses, it's not very large. So again, a 30-minute conversation on your cell phone just next to your head probably does it. So.
Right, and could you give a little more information about MST for bipolar depression?
Absolutely. The contact for the research coordinator, Michelle Avina, would be the best, the most straightforward way to learn more about the trial that we have, and definitely still ongoing. We're recruiting and we continue to do it. So yeah.
And we had entered Michelle's contact information into the chat, so it is there for anyone who would like to see. Just scroll through many questions here. Okay, can this treatment be used in conjunction with psilocybin or psychedelics?
Psychedelics is the question of the year. It's coming up a lot. We are hearing a lot on the news. It reminds me, there was a time when I started Parkinson'S clinic in 2015 or 2014. I recall getting a lot of questions about cannabis, and cannabis was the question is, can cannabis help for this or for that? It feels a little bit that way with psychedelics. There have been a couple of trials in depression. One of them in a high-profile journal was actually negative. So I think it's really important to remain open to new treatments, and I think psychedelics will have its role, but it's early days. I've not seen any use of psychedelics in Parkinson's. I've seen it in major depressive disorder, PTSD, and situations with psycho-oncology, so end of life use of psychedelics in the context of psychotherapy. So I think data that are coming out are exciting. I think it's going to be a tool that it's going to be helpful in some circumstances, but I remain cautious about its widespread use for anything and everything. I'd be cautious.
Okay, great. And just one more question here, since we are nearing 1 o'clock. This goes back to your clinical trials. Are your clinical trials including people with Parkinson's disease who have motor symptoms only and no depressive symptoms?
Not the current trial, but I have been thinking about that a lot. And so I think after we conclude this trial, the hypothesis, what we believe we're going to find is that it not only helps with the depressive symptoms, but it also helps with the motor symptoms. So one of the objectives stated on the trial protocol is we want to measure if there's an effect on motor symptoms. And the hypothesis is that we will see those. And with that information, then the plan is to go back to funding agencies and say, hey, look, I think it's worth doing this as well, only in people who only have motor symptoms in Parkinson's, because it's helping and it has very few side effects. So I'm hoping we get there in, I don't know, 3-4 years, but I'd love to see that.
Right, for sure. And all this new research is certainly very exciting. Just one last question here is, are repeated treatments with MST needed to change the brain over time?
So it's really important to emphasize again that a course of MST, magnetic seizure therapy, or ECT, involves several treatments several times a week, so 2 to 3 times per week, for anywhere between 10 to 15 treatments. In the context of major depressive disorder, oftentimes we need to do some form of maintenance, which it's anywhere between 1 to 2 treatments every month or every 6 weeks.
Sorry, Dr. Rodriguez, you are frozen.
I think
you're back now.
We're back now.
Yes.
What I was saying is that the person that I originally treated back in 2011 was getting maintenance ECT one treatment every 6 weeks only. So yeah, several treatments are needed to complete a course and to treat an acute depressive episode.
Well, thank you so much for answering all of these questions. There are lots of questions in the chat, and this is a very interesting presentation. So thank you so much for your presentation and helping us all learn so much about non-invasive neurostimulation therapies.
No problem. I really appreciate the opportunity, and we'll work on putting materials on our website as well, so that people who want to learn more can also check and get more information. But yeah, send us an email, and we do check our emails and we do respond to them. So yeah, don't hesitate to reach out.
Yes.
Thanks so much
Well,
for the
thank you so much. Yeah, sorry for any questions that were not answered, but we do have our brain.wellness@ubc.ca email in the chat. But please feel free to reach out. And otherwise, that wraps up today's session. Thank you so much for joining, everyone. And I hope you all enjoy the rest of your day.